So good morning, good afternoon, everyone, and welcome back to our webinar series, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. In today's webinar, we're looking forward to discussing moral injury and moral distress in long-term care. My name is Tanya McDonald, and I will be moderating this session from my home office in Ottawa, Ontario. I would like to acknowledge that my home office in Ottawa is on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, and I'm proud to call this place my home. From this territory, we are pleased to offer today's webinar with French simultaneous interpretation. If you wish to listen to this session in French, then please select French from the interpretation menu at the bottom of your screen. We invite you to use either official language when entering your questions and comments in the chat box. This session will also be recorded and a summary will be available for review or to share with your colleagues who have missed the session. So the LTC Plus program and webinar series are based on the Reimagining Care for Older Adults report that we published over a year ago, which focuses on 6 key areas that have the potential to reduce the risks of future COVID-19 outbreaks or mitigate their effects. We're also pleased to mention that we have 2 upcoming reports that are coming out or that are just been released. So the first is Promising Practices for Supporting Long-Term Care Providers' Resilience. And we've just released this report by Dr. Carol Esterbrooks and the TREC team from the University of Alberta that focuses on resilience through the COVID-19 pandemic. You can read the full report from our website under the LTC Plus resources and promising practices. We've also released a second report with the Nova Scotia Centre on Aging, focused on supporting in-person family presence and communication with families in long-term care. We will put links to both of these reports in the chat during the webinar. And as always, we'd like to recognize the partners with whom we have been working with over the past year and a half to support this program: BC Patient Safety Quality Council, New Brunswick Association of Nursing Homes, CADIF, and the CMA Foundation. So it's now my pleasure to introduce our speakers for today. So we have Marianne Notariani. She is the Vice President of Knowledge Mobilization at the recently established Center of Excellence PTSD. In this role, Marianne oversees initiatives to support the application of research evidence and the implementation of evidence-based practices to improve supports and services for veterans, first responders, and their families across Canada. She also provides leadership to the center's growing network of networks to ensure the expertise of lived and living experience valued equally alongside technical expertise in guiding the center's work. We also have Fardaus Hosseini. He is the Deputy CEO and Vice President of Research and Public Policy at the Center of Excellence on Post-Traumatic Stress Disorder, PTSD, and related mental health conditions, located at the Royal Ottawa Mental Health Center in Ottawa. His research focuses on strategic policy issues related to mental health and system transformation, parity legislation, substance use and addiction, and mental health for newcomers and underrepresented groups. So over to you.
Well, thank you so much, Tanya, for that warm introduction, and thank you to Healthcare Excellence Canada for the invitation to speak to you all today on this important topic. And a huge thank you for all the participants joining this discussion. As Tanya mentioned, my name is Fardaus Hosseini, and I'm the Deputy CEO and Vice President of Research and Policy at the Center of Excellence on PTSD. And I'd like to also echo Tanya's land acknowledgement. The Center of Excellence for PTSD is located in Ottawa on the traditional unceded territory of the Algonquin and Anishinaabe peoples. Next slide, please. So from recent headlines, it's quite clear that the impact of the pandemic on healthcare workers has reached a critical level. Currently, healthcare workers are overworked, overwhelmed, and are experiencing challenges and organizational stressors unique to the pandemic. As such, understanding the health and well-being of our healthcare workers is a critical step in promoting a healthy and safe workplace. And that's what brings us here today. Next slide, please. Before getting into our discussion about moral injury, let's first address morals. Broadly, morals are the answer to the question, how should we behave? According to Haidt, morals are an interlocking set of values, virtues, norms, practices, identities, and evolved psychological mechanisms that work together to suppress or regulate selfishness and make social life possible. Haidt proposed 6 foundations of morality in his moral foundations theory. The first is care, which is protect and cherish others versus harm. The second is fairness, which is provide justice in line with shared rules versus cheating. The third is loyalty, having standing within your group, family, country, or colleagues versus betrayal. The fourth is authority, so respect, following tradition, submission to legitimate authority versus subversion. The fifth is sanctity, so purity or avoidance of improper things or actions versus degradation. And then liberty, which is the opposite of oppression. So this theory of morality, well, one of many, gives us insight into some of the dimensions that are compromised in moral injury. It is also important to note that morality differs from culture to culture, and it can vary within communities or social groups. Next slide. So what is moral injury? Currently, there's actually no clear consensus on a definition. In fact, a literature review from 2017 indicated at least 17 different definitions, all with slight variations. There are, however, some common elements. The concept of moral injury was coined by clinical psychiatrist Dr. Jonathan Shea to capture the experiences of military members and veterans whose mental health and other issues were similar to, but did not meet the criteria of PTSD. He describes moral injury as a betrayal of what is right by someone who holds legitimate authority in a high-stakes situation. In this definition, the key components are authority, so someone with the power to affect the outcome of a situation, a high-stakes situation where the degree of risk is high and where one's decisions or actions have the capacity to cause harm, and the betrayal of trust, confidence, or a moral standard. This initial definition and most research conducted on moral injury have been related to military and veteran contexts. However, there's now a growing number of studies in other contexts, including healthcare. As mentioned by Borges and Barnes in a 2020 study, the COVID-19 pandemic has made it clear that moral injury's relevance extends beyond the battlefield. For instance, Dr. Wendy Dean linked the concept to healthcare. She describes moral injury as a challenge of simultaneously knowing what care patients need, but being unable to provide it due to constraints that are beyond the individual's control. Considering all the definitions, what can be agreed upon is that moral injury is the psychological, social, and spiritual consequence of events that seriously violate core moral beliefs and expectations. And these events are called potentially morally injurious events, also known as PMIES. Next slide, please. One more. So yeah, over the next two slides, I want to just highlight the key few of the definitions in moral injury that are often most cited. And together, these definitions contain core elements of what moral injury is, what it might feel like for a person. So the first was, as mentioned earlier, was Dr. Shea, who describes moral injury as a betrayal of what is right by someone who holds legitimate authority in a high-stakes situation. Brett Litz and his colleagues from Boston University added to this definition. Their expanded definition acknowledges the types of consequences that such actions may bring about. It also emphasizes that moral injury can arise not only from feeling betrayed by others' actions, but from one's own actions when they violate deeply held beliefs about what is right. Next slide. Gabriel Letney and Brock added to this definition by looking at moral injury as a wound in the soul. And then finally, Jeremy Jinkerson added to the definition by taking a syndrome perspective. And it's these collective four definitions that are most often cited in the literature. Next slide. So when we talk about potentially morally injurious events, there are two broad types. The first is those that involve people doing or failing to do things themselves, so acts of commission or omission. In the context of COVID-19, this might include taking a patient off potentially life-saving treatment to make it available for other patients, or failing to properly screen a patient, resulting in other patients being exposed to COVID-19. The second type is being exposed directly or indirectly to transgressions on the part of someone else. So this could include a healthcare system's rationing of resources and may not have helped save lives or watching a colleague fail to follow PPE protocols. Next slide, please. It's also important to understand that moral injury exists on a continuum which includes moral distress, which is less severe than moral injury. This continuum outlines the moral challenges and stressors are more frequent than morally injurious events, and that moral frustration and moral distress are more common outcomes. In the same way that not all individuals who experience a traumatic event will experience PTSD, not all potentially morally injurious events will lead to moral injury. In the milder degree on the left, an individual may experience morally challenging events which tend to occur more frequently, and these may lead to feelings of moral frustration. In the moderate degree, in the middle, people can experience moral stressors or events that cause a greater degree of moral distress. These are more acute than moral challenges and are likely to lead you to feel more salient moral emotions like guilt, anger, and shame, or moral distress. Often, moral distress can be a normal response to these events and can be productive in affirming one's moral beliefs and in preserving relationships or communities. Morally injurious events are in the extreme degree. They are located on the right side of the continuum. Morally injurious events are severe, lower frequency events that have a distinct impact on mental well-being and can cause more severe psychosocial harms that can impact someone's daily activities, relationships, and functioning. If you experience moral injury rather than moral frustration or moral distress, you're more likely to see yourself as marked by the experience and to define yourself and or others in relation to the events. As mentioned earlier, not all morally challenging situations or events lead to moral distress or injury. Some experiences, although painful, may in fact lead to moral growth because they prompt self-reflection or new insights or strengthen character. Next slide, please. The very recent application of moral injury outside of military and veteran contexts to healthcare and public safety personnel contexts has led to new debate about the difference between moral distress and moral injury. The concept of moral distress was first developed in 1984 to describe the impact of situations in which healthcare professionals, specifically nurses, know the right thing to do but can't. This definition resembles Dr. Dean's definition of moral injury presented earlier. It is therefore important to emphasize some of the similarities and differences between both in order to understand when moral distress may turn into moral injury. In terms of similarities, both moral injury and moral distress include the element of moral integrity. That is, both reflect the personal relation to moral values and beliefs. As well, they share some similar psychological consequences such as guilt, self-blame, blaming others, anguish, and a sense of powerlessness. Where they start to differ is in relation to the context in which they occur and in severity of the consequences of these events. Moral distress can emerge from a sense of moral conflict or stressor in morally distressing situation, which are caused by external constraints such as policy, structure, or bureaucracy, or internal characteristics such as moral sensitivity, threatened values, inability to demonstrate moral action, or powerlessness. This situation can lead to psychological imbalance and negative feelings like blaming others or oneself, depression, anxiety, feeling embarrassment, or anguish. With moral distress, these consequences will, however, not have an impact on one's moral framework. Looking at moral injury, this can emerge following a potentially morally injurious event, which consists of both external factors, so a high-stakes situation, one that's beyond your control and in a broken system, and in internal factors when one is perpetrating, failing to prevent, or bearing witness to moral transgressions. This event can leave the individual with a deep emotional wound and an eroded moral framework. People who struggle with moral injury have made enduring self-attributions about themselves or others. More broadly, moral distress represents a form of situational problem due to external or internal constraints, while moral injury represents an experience of the problem that results in a long-lasting change to an individual's sense of losing hope, trust, integrity, and so on. Events leading to either moral injury or moral distress differ in the likelihood that the experience and impact will alter the individual's identity. The accumulation of many moral distressing events may also lead to moral injury. Next slide. Moral distress is not the only concept overlapping with moral injury. For instance, compassion fatigue may lead to moral injury, and moral injury may be a risk factor for PTSD, burnout, depression, and anxiety. Specific to healthcare workers, some researchers suggest that moral injury is often mislabeled as burnout. Next slide. Focusing solely on PTSD and moral injury, they both overlap in a number of ways. Both involve an extremely stressful event that produces psychological distress. Both involve re-experiencing events. Both involve negative thoughts about yourself, others, and the world, and both involve negative emotions and feeling detached from others. However, there's also some few differences that are quite clear. Next slide, please. The first difference that I want to highlight is the origin or cause. So events that lead to PTSD involve threat to safety, physical integrity, and threat of death. However, this may not be the case for moral injury. The emotional reactions are different. So guilt and shame are common in PTSD, but fear-based conceptualization of trauma, like horror and helplessness and recovery, dominate for PTSD. But guilt and shame are more central to the understanding of moral injury. The attributions. In PTSD, there's an understanding that negative beliefs resulting from trauma are erroneous or exaggerated. This may not be the case for moral injury. An individual may have really committed abuse, and the person should be held accountable. Another difference is the physiological stress. The symptoms of exaggerated arousal, which are commonly seen in individuals struggling with PTSD, may not be associated with moral injury. And the final difference is the function of symptoms. So avoidance is a core symptom of PTSD, and we may see it in moral injury as well, but instead of avoiding reminders of an experience, they may avoid social judgment for fear of being found out as a morally bad person. Next slide, please. As noted, it's only recently that researchers and clinicians have started to explore the presence of moral injury outside of the military and veteran context. There's a growing amount of evidence showing that moral injury is also experienced by healthcare workers, including and most importantly during the COVID-19 pandemic. Next slide, please. So while people may choose a military or healthcare vocation because of a desire to help others, the difference with healthcare is the oath of do no harm. In the military context, moral injury may arise when a soldier has been forced to act against their deeply held moral beliefs. For example, failing to intervene to protect civilians because to do so would have been a breach of the rules of engagement. In the healthcare context, the deeply held moral belief that can lead to moral injury if transgressed is the oath that healthcare providers take to put the needs of the patient first. When healthcare workers are unable to follow their oath, they may experience moral and ethical dissonance. This is especially relevant considering the current COVID-19 pandemic and the risk this has presented for morally distressing or potentially morally injurious events. For example, recent studies indicate that events such as the rationing of PPE and the potential contact with the virus are contributing factors to moral distress in healthcare workers. In fact, a recent study found that Canadian healthcare workers' perception of COVID-19 risk was positively associated with levels of moral distress. Next slide. Other examples of moral challenges or stresses that may be specific to healthcare workers include staff shortages leading to compromised quality of patient care, medication errors and preventable patient deaths, technology failures, condemning or non-supportive work environments, and having to choose between safe working conditions and quality of patient care. Next slide. Although there's very limited research on the potentially morally injurious events specific to long-term care settings, parallels seem to exist between the previously mentioned PMIES and the long-term care setting specific challenges laid bare by the COVID-19 pandemic. Specifically related to staffing and equipment, according to Stats Canada, more than half of all Canadian nursing homes reported critical staff shortages, and about 1/3 of nursing homes reported a critical shortage of PPE for staff in 2020. Furthermore, there's anecdotal evidence that situations such as the inability to provide residents a dignified death, having to leave residents to die alone and in distress, and being unable to comfort residents through a hug or touch were PMIEs experienced by some workers in LTC settings. Next slide, please. It is increasingly being recognized that healthcare workers are at risk for moral injury as they encounter challenging or traumatic events that may have a lasting psychological impact. More research is needed to confirm these observations and to examine the prevalence and mental health impacts of moral injury in other populations, including healthcare workers. Next slide. So what are the impacts of moral injury? Next slide. This slide shows the core domains of moral injury as identified by Dr. Bill Nash. Dr. Nash was a Navy psychiatrist for 30 years and was the director of psychological health for the U.S. Marine Corps. Now, his work focuses on developing models of moral injury, as well as tools for the prevention, assessment, and treatment of moral injury and stress-related problems in veterans. Nash describes 6 core domains of human experience that are impacted by moral injury. First is emotional experience. Second is loss of identity. The third is impaired self-regulation. Fourth is spiritual connection. The fifth is concept of self and world. And the sixth is relationships. These 6 core domains of human experience are all impacted by moral injury. Next slide. It's also important to speak to the flip side, to the positive or moral emotions during COVID-19. A number of researchers highlight the protective value of the professional underpinnings of healthcare, including a sense of service and purpose, a strong commitment to moral codes, justice and service to others, altruism, and courage. These attributes may be, in fact, enhanced through facing adversity, where the appropriate system, team, and individual supports are available. A number of factors have been identified as supporting the well-being and motivation of healthcare workers. These include positive role models, supportive teams, and appreciation from all levels of the organization, strong empathetic leadership, camaraderie, feelings of effectiveness, and pride at making it through adversities. In particular, experiencing adversity can highlight positive attributes of altruistic caretaking, compassion, personal sacrifice, and validation of existence. Next slide, over to you, Mary.
Thanks. So we also want to acknowledge the impact of racial disparities on mental health and in the healthcare sector, and how they may cause and or exacerbate moral distress in racialized healthcare workers during the context of this pandemic. Next slide. So the COVID-19 pandemic has really laid bare the impact that systemic racism and racial discrimination can have on the physical and mental health of racialized people. In Canada, we've seen rates of infection have coincided with race as more racialized people live in neighborhoods with the highest rates of COVID-19. Racialized people have been at higher risk of exposure to COVID-19 because they're more likely to experience income inequity and poverty, live in high density neighborhoods, live in congregate housing settings, experience housing inequity, use public transportation, and work essential service jobs with greater workplace exposure. Next slide. Healthcare workers of color, including long-term care workers, have been grappling with the pandemic alongside persistent systemic inequities in healthcare and growing national attention to racism. Some of these inequities include challenges speaking out against racism in fear of retaliation, facing skepticism about their training or competence, witnessing colleagues make racist comments, or experiencing racism from colleagues or patients. This is especially relevant when looking at long-term care settings, as many care workers in Canada and in fact around the world are migrants. Most recent census data shows that over 1/3 of nurse aides, orderlies, and patient service associates in Canada are immigrants or visible minorities. This percentage varies throughout the country and can reach up to 50% in some provinces. In comparison, this population group represents 21% of workers in all other occupations across the country. And looking only at profession, the Canadian Institute for Health Information has demonstrated that risk of COVID-19 infection also varies by health professionals, with personal support workers in Ontario, Manitoba, and BC having a 1.8 times higher risk of being infected with COVID-19 when compared to nurses, and a 3.3 times higher risk compared to physicians. We also know that healthcare workers of color have reported stress because of identification with patients and the need to keep their frustration with health inequities to themselves. As a result of dealing with the stressors of systemic racism and care provision during COVID-19, racialized healthcare workers, including long-term care workers, may be at risk of experiencing psychological and moral distress and injury. Next slide. So recent studies have concluded that understanding what moral injury is and the possible and multiple impacts that can arise following exposure to potentially morally injurious events or potentially psychologically traumatizing events is just the first step. Next slide. Before we talk about how to recognize moral injury, we need to contextualize some of these points. So remember that as Firdaus was discussing, moral injury is not yet fully defined, and its features are those that are common to other problems or forms of distress. So for example, anger and guilt that Firdaus was speaking about. We risk pathologizing individuals if we immediately conclude that the expressions of symptoms are moral injury. Given the experience of potentially morally injurious events, moral distress is understandable. We don't want to assume that because someone has experienced a potentially morally injurious event, that they have moral injury. Individuals with moral injury are likely to hide their experiences. So it may take time, patience, tact, empathy to bring this out. Being too direct can create the risk of prompting more distress. The best thing we can do to recognize moral injury first is to be aware of it. It's also likely easier to recognize features of moral injury that are behavioral, like isolation or withdrawal, lack of purposeful behavior, and aggression, rather than emotional features. Guilt, shame are emotions that prompt withdrawal and secrecy, that fear of being found out. If you think a colleague has experienced a potentially morally injurious event or moral injury, create a safe space to discuss more potentially morally injurious events or moral injury. Acknowledge the moral stresses or difficulties inherent in the work. Listen with patience and compassion, and encourage colleagues to take care of themselves, engage in activities they enjoy and derive meaning from, foster social connection, and approach without judgment. Next slide, please. So research into how to promote and encourage moral repair remains ongoing, but some common recommendations include accepting reality of past moral wrongs and moral pain, forgiving self and others, participating in meaningful and rewarding activities that help an individual confirm that life has meaning. It's also important for us to prioritize our own values over the moral rules set by society. The values that individuals determine and define for themselves are easier to live up to than ones that come from an outside and much bigger moral order. Next slide. Practicing self-compassion is critical. You need to be open to moral pain and associated judgments of yourself as just one aspect of being human. And you need to be aware of your sense of self, who you are, your identity or character, and how that is distinct from the moral pain you might be feeling. It's also important to identify the supportive people in our lives in order to create an atmosphere of acceptance, build or rebuild strong social attachments. And when these options don't work, it's important to consider professional support. Mental health professionals can help you talk about and process your reactions and feelings in a confidential and supportive environment. In terms of treatments, although some, such as acceptance and commitment therapy, have been developed for moral injury, current research on treatments is still in its infancy stage. There are, however, some clinical trials in progress which could help inform how moral injury is treated going forward. Next slide. So moral stressors are inherent in the COVID-19 environment and can't be designed out of the work. The onus, therefore, is really on organizations to implement a preventative and early intervention approach, which can reduce risk and maximize protective factors rather than simply reacting to issues when they arise. A whole of organization approach is recommended as the best practice approach to managing potentially morally injurious events and mitigating the risk of moral injury in various healthcare settings. So this also includes a consideration of the role of managers and leaders, well-being support services, both professional and peer, as well as individuals' own coping resources. Social support, both internal and external to the work environment, has consistently been shown to be a protective factor towards the development of post-traumatic and other mental health conditions. And peer support in particular has been shown to be an important protective factor following trauma exposure. Next slide, please. So what can organizations do? It's important for workplaces to acknowledge the occupational stressors that healthcare workers may face, such as physical strain, physical isolation, extreme fatigue, which can be contributed to by shift work, as well as by wearing what may be hot and uncomfortable PPE, the constant awareness and vigilance, procedural pressures, tension between public health priorities and patient or family wishes and needs, and conflicting personal and professional demands. In the context of COVID-19, a particular source of stress has been the uncertainty that's existed, including changes in guidance and directive. So it's recommended to maintain open communication between colleagues and, importantly, from leadership about what is known and also what is not known. So some other tangible action items include providing strong leadership and establishing cohesive teams with high morale, being prepared to discuss moral and ethical challenges, helping team members make meaning of moral stressors, modeling positive coping and encouraging help seeking and self-care as required, celebrating successes, however small they might be, arranging regular check-ins with staff to monitor well-being, and facilitating referrals for further support if required. So overall, this reinforces the importance for organizations of promoting a supportive culture within the workplace and arranging access to a range of support services for staff as part of the regular way of doing business to build in protective factors to be in place in case of future crises. Next slide. So research suggests that cohesive teams with high morale may be better able to protect their members from adverse impacts of extreme moral stressors. So team leaders, unit leaders, people leaders are critical in preventing and responding to moral injury. They can promote those cohesive teams with high morale, cultivate a culture of safety, non-judgment, and care, have frank discussions about the moral and ethical challenges staff will realistically face, discuss potentially morally injurious events and potential social, emotional, and behavioral responses to exposures. They can also make sure to put time aside to have those check-ins with teams, encourage debriefing, and importantly, acknowledge and affirm experiences that are shared. So for people leaders, it's important to not be dismissive of someone's feelings and experience, but rather validate what someone has seen or been through. And it's also important to be aware of the potential for staff to avoid talking about moral stressors and be prepared to reach out and proactively offer support rather than wait for staff to come forward. And in offering support, team leaders can listen out for narratives, beliefs, or statements that suggest someone may be struggling with a sense of moral failure or guilt and help them to stay grounded and focus on aspects of the situation they can control while acknowledging what they can't control. Providing that acknowledgement and affirmation and giving meaning to events in such a way that reduces feelings of powerlessness helps to reinforce the mission and sense of purpose. And it's also important for leaders to model those positive coping skills and encourage self-care and help seeking. Next slide. So there are also those important steps that we as individuals can take to manage in the face of morally challenging or stressful events. So for instance, learning more about moral stressors and moral injury, taking care of ourselves by eating well, exercising, maintaining social connections, ensuring adequate rest, engaging in stress reduction activities like relaxation therapy, mindfulness, or meditation, engaging in self-reflection, self-expression activities, connecting with peers, and supporting colleagues during shared experiences. And importantly, for individuals, seeking professional support if you're feeling distressed or troubled by your experiences. Next. We should not overlook the responsibility that needs to be shouldered across the community and the government for how we treat healthcare workers and the narratives that are created around the difficult choices that they may have been forced to make, as well as the narratives that have influenced who gets celebrated in public and who doesn't. So we recognize how this pandemic has shone a significant spotlight on overburdened or inadequate systems and policies, including how it's highlighted systemic challenges related to long-term care delivery. There needs to continue to be a push to look at broader systems and push to prioritize the strengthening of our care delivery models. Next. So for more information about moral injury and these recommendations for this whole of organization approach, we encourage you to download our guide to moral injury at moralinjuryguide.ca or visiting our website. It's available in French and English. The guide promotes a framework or a map for how to implement preventative and early intervention structures to support care workers before they're morally injured. And it outlines examples of those supports that can be provided at the organizational team and individual levels. Next. We've also recently soft launched a new toolkit for leaders that will continue to be populated over time. Next. So we launched the first session, which features quick tip sheets and guides directed at senior leaders and managers. Section 2 will be launching Monday next week and will feature tools to support organizations in asset mapping. The purpose of these tools will be to help leaders recognize and promote existing practices, policies, and programs within their organizations that support employee psychological health and safety. We recognize that there's already work underway in many organizations and settings that can act in support of the whole of organization approach that I was speaking to earlier. The subsequent sections will provide tools to support developing, implementing, and evaluating a plan to put in place preventative and early intervention structures to provide proactive universal support for all staff. We'll also be launching a video series featuring the voices of leaders from various sectors sharing their tips and experiences. So you can visit our webpage, sign up for updates, or follow us on social media to stay informed about these new tools. And I'll throw the link in the chat as well. Next. So would like to just take the time to thank you all for listening and thank Healthcare Excellence Canada again for allowing us to present to you, and we'll look forward to your questions.
Thank you very much, Marianne and Fardos. Really appreciate this overview of moral injury. While we wait for some questions to pop into the chat, I did receive a few, so I'll start with the first one. Can you, at the beginning of the presentation, you mentioned that moral injury is different from burnout, and I'm wondering if you could expand on that a little bit more. So I don't know who wants to go first. Maybe I'll go with Fardos.
Sure, thank you. Tanya, again, yeah. There's been conversation happening, and given the fact that moral injury is still a very new construct as it's being studied in the healthcare community, people have mistaken the two for, either moral injury or burnout. And there are a lot of similarities, but they are still phenomenologically distinct. So, burnout is emotional exhaustion, and moral injury, on the other hand, is associated with profound distress and includes emotions of shame, guilt, or self-loathing. So in burnout, we don't see that sense of shame, guilt, or self-loathing. But in moral injury, that's central to its understanding, that you were put in a situation where your moral code was violently assaulted, or you're challenged significantly. And in burnout, that's not seen. So that's a prevailing difference, is in that intense emotional reaction that one has versus the other.
Great. And I'm just wondering if you could comment too on how leaders and organizations could differentiate between the two based on the behaviors or the conversations that they're having with their healthcare staff. So maybe Marianne, did you want to start with this one?
Sure. And then I'll turn it to Fardos if there's anything to add. I think one thing that, speaking to what was I was mentioning earlier, is around when you're having those conversations and what to listen out for, what to observe. So as Fardos is saying and talking about burnout being that emotional exhaustion, and when we're talking about experiences with moral distress, really understanding some of the commentary that might get at some of the emotions like guilt or shame, or talking through experiences. And so having this awareness around what a potentially morally injurious event might be, or using the information that you're hearing today to be able to draw that out and ask those questions, could provide some sense of how to direct the conversation and type of supports, right? So things like burnout might be related to workload or those types of concerns, whereas, moral experiences with moral distress, moral injury may give you other avenues to debrief, to help them again make meaning of moral stressors, connect back to that sense of purpose, helping them focus on what's within their control, beyond their control, and so on. So understanding the differences and just understanding what to listen out for and being aware of this can hopefully provide you that sense to have more of an ability to ask those probing questions, to try to make those distinctions, and then offer different options in the supportive conversations you may have or as you debrief. I'll turn it to Fardaus to see if there's more to add that I may have missed.
No, I think you captured it really well, Marianne. The only piece I would add is the importance of those check-ins, right? So if leaders don't have those check-ins with their staff or their frontline staff, they won't be able to appropriately identify when someone is struggling with burnout or someone is struggling with moral distress and moral injury. It's so important to make that time and to actively be listening in those conversations, not just check the box of how are you, how's it going. You have to actually be doing a bit of a deep probe, and it might be very difficult in the beginning to create that space. But if over time, if your staff can trust you and know that you're actually putting in dedicated time to hear them out, you'll be able to figure out what it is that they're feeling and how to support them in that situation.
And I guess building on that one, thank you. Just wondering if there's any particular approaches that need to happen. I mean, we've been in the pandemic for about 1.5 years now. I'm imagining that multiple professionals within an organization are suffering from this. And so I guess, are there different strategies when it's, a large percentage of your workforce that is struggling with this moral injury or moral distress, which is probably particular during this time of a pandemic versus just having, 1 or 2 individuals? I think maybe the approach might need to be a little bit different. I don't know, Marianne, if you want to comment first.
Sure thing. I think, there's still a lot that we're learning and researching, and there's studies ongoing and underway, and we're part of those as well to see what we can advance and put out. There's a bit of that need to continue to build the evidence base and use that to inform recommendations that organizations can draw on. Something as well, I think, to be mindful of when you're saying that there's a number of people that may be going through shared experiences is the potential for that peer support. And we've talked about, drawing on other research and our understanding of how peer support may be particularly helpful following trauma exposure, that, are those opportunities to build in those structures within your workforce or tap into that within other networks. And that's an example I think we've seen or have heard of, at least anecdotally, from different health institutions around, making that available. And maybe I'll see, Fardaus, if you have more that you want to add in response to that question.
I think just highlighting what you mentioned, Tanya, around the different levels. So we've heard, from board members to senior staff, executives, to all the way to the frontline staff, there's different moral distress and morally challenging events that they're all experiencing. So when you're looking at supports to be offered, there has to be, of course, some sort of standardized support, but there also needs to be some personalized individual supports that can be made available to each of these levels, and especially focusing on those frontline healthcare workers who are continuously being put in positions to make these difficult moral decisions. But there is a need for more personalized approaches at these different levels, which I'm hoping with our tools that we're developing, we're going to be taking a bit of a more comprehensive stance on that.
And I think too, just to add, I think we recognize that there are some of these bigger sort of system challenges, and what this is doing is really reinforcing the need to ensure that those supportive structures are in place, so that, again, anytime these types of big challenges, whether it's going to be like COVID-19 pandemic or on a smaller scale, that there are already resources and systems in place to be supporting the health and wellness of the workforce. So I think, we've seen how this really has, as we mentioned, kind of shone a spotlight on some of the weaknesses, if you will, within systems, and how people are already, as care workers, maybe already feeling stretched thin or having some of these experiences. So what this hopefully does is provide that opportunity to be forward-looking and use this to really build up those experiences. And what we're hopeful for around these conversations is that as the understanding around moral distress and particularly moral injury in this healthcare realm, it's getting more attention these days. And as there's more research going into it, we can ensure that there's a wider and broader toolkit and more comprehensive supports that organizations can draw on. Naming and having that awareness is really a first step in order to address it effectively.
Yeah, I agree. So we have a comment and a question. So I'll ask Fardaus to respond first. So if the treatment to repairing moral injury, as you stated, is saying what is happening, so being transparent and clear and recognizing the injury in order to move forward and repair, For family caregivers, there was great moral injury. As we know, many long-term care facilities closed their doors to essential care partners throughout the pandemic. And there was felt that there's a culture of deny, defend, and repeat injury. So who is addressing their PTSD? So of the essential care partners who throughout the pandemic, who have also suffered.
Well, absolutely. Thank you so much for that comment. And I think we can't lose sight of the different populations that have been affected and to the degree that they've been affected. So I would say, I would agree with the comment that, family caregivers who have been put in positions to have to shut down their doors, they can't be there for loved ones. These are all potentially morally injurious events. And if you're continuously facing these on a daily basis, you'll be marked by the experience. And as a result, we can say, moral injury has been seen or someone has been struggling with moral injury. So I think, this is one of those situations that we have to continue in a spotlight on it to ensure that folks are aware that we've put these healthcare workers and these family caregivers in a situation to make these difficult decisions. And now what are we doing to help support them? So it's one thing to name the problem and address it and put some awareness and spotlight to it. But now it's important to also offer the supports for that individual to be able to make sure that they're now being taken care of and that their well-being is of paramount importance and focus right now. So I don't know who's taking care of it, but I think there's, leaders have a role to play, organizations have a role to play, and the government and community has a significant role to play. As Marianne was mentioning earlier, that, the pandemic has only shone a light on a situation that was already existing. We heard from healthcare workers that, I was already putting in 14 to 15 to 16-hour days before the pandemic. Now, we just have the spotlight and the highlight, it's being highlighted. So what are we going to do to address some of those systemic issues? Because if we don't address the underlying system issues, then we can't continue putting the onus on individuals to also take care of their well-being while they're also putting in those long hours. So I think it's important to continue advocating for system and change and government to intervene because, they've created a system that needs a bit more support to be more supportive in their approach.
I would also add to the importance again of seeing family caregivers, patients as partners in the system and thinking through, like, going forward, are those policies for how to handle something like this in the future being co-created? And so again, I know there's been a lot of movement, Healthcare Excellence Canada being an organization that's been, really moving this and advancing some of the conversation forward. Certainly family caregivers, patient partners themselves, I think, have really been at the forefront of pushing for more of that partnership model in our whole healthcare system delivery. So I think there's an opportunity there to ensure that, as organizations maybe look back at some of the lessons learned and plan going forward and think about what structures need to be in place, that if everybody's at the table, it needs to be at the table, that they can co-create that together going forward.
Absolutely. And just speaking to the system challenges, there's a comment that healthcare workers have historically been minorities, as you've mentioned, Marianne, in your slides, ethnic and racialized, and essentially mostly women. And so I guess the big question from a system perspective is, can we meet this challenge, in the future, facing the upcoming economic challenges associated with this workforce? There's a question also about the leadership remaining sections of the toolkit. So do you have a timeline for creating the remaining sections of your toolkit? So maybe I'll go to Marianne first, since they were in her slide deck.
Absolutely. Yes. And that's a great question. So we were happy to have some tools available for you to start interacting with using. Send us feedback. Of course, we always welcome that. And they're actively underway. So the remaining sections. So we don't have a specific date, but over the next few weeks, by calendar year end, everything should be up. And we say that, and we're also looking to continue to populate in an ongoing way as we hear about what's useful and what may be helpful, recognizing that some of these tools too can apply to other scenarios and be applicable across a range of sectors. So the sections that you formerly saw in that slide and that I spoke to should be up by the end of December, and we'll continue to promote and send out links and share when new content is added.
So Fardos, the next question's for you. Are there any specific strategies for managing moral injury for those within an organization's leadership group? Leaders are often in the position of supporting others while trying to manage sometimes very distressing and rapid changes in policy and procedures from the government level. So are there any specific, anything specific for that group?
It's an excellent question, Cynthia. And again, I think anecdotally, we've heard stories where leaders have been put in positions where their frontline staff have asked to be deployed to a specific unit where they know that the risk of COVID is higher, and then the leaders put in that kind of situation where they want to protect their staff, but they also want to respect their wishes and their ask, and that is also something that they've been challenged. Their moral code has been challenged, where they're like, do I put my staff member at risk even though they're asking for it? How will I feel if something happens to them? So it's addressing and speaking to that narrative. It's being able to have those conversations. And I think organizations have to create a culture where they're allowing for people to make meaning of those moral stressors. It's being prepared to discuss moral and ethical challenges. It's providing strong leadership and establishing cohesive teams so that the leader is not on their own. So there's open communication between colleagues on a leadership team. You have to continue modeling those positive coping and encouraging self-care and help seeking as required. As Marianne mentioned, it's important to also be celebrating successes, however small they may be. So these are small, tangible action items, and we're hopefully with our toolkits for leaders, we're going to have a bit more information on additional tangible action items. I don't know, Marianne, if you want to speak to that a little bit, but it's creating that kind of environment where folks can have those conversations and an individual doesn't feel like they're left on their own to making these decisions, and then having that stew over time is not really helpful. So create that space to have that dialogue and not be on your own. So make sure that communication is open and transparent.
Exactly. And I know one thing we were hearing is that importance of that message for leaders to say to their staff, like, we've got your back, and convey that message, right? And so it's who is a leader's back and how are they being supported? And so being mindful of those suggestions and the points that Fardos was raising around, and like going back to the importance of having that cohesive team around that extends at your management and leadership teams, engaging in self-care and having that positive coping is certainly important. And one thing I think when, we think about the tools, we can look at things that we've developed with a view to team leaders, people leaders, for what they can use in their staff. That some of those can also be, it can equally be used in the context of conversations with your colleagues or your fellow leadership team members. So, there's going to be tips in there around showing gratitude, listening guides, like suggestions for how to have and open up some of those conversations. So just as that can be applied in the context with an employee, it could similarly be, applied if you're noticing something or just wanting to have debriefing sessions with your colleagues. And again, ensuring that there are those sort of social support and peer support kind of structures in place with colleagues is important, and in tapping inside and outside the workplace as well for leaders. So who are their maybe peers across the system that they can connect with and talk about shared experiences as another avenue of having support.
Great. So lots of thank yous coming in, one in particular from someone who receives home care services from 2 personal support workers, and it is really important that we address the mental health and well-being of the workforce. So thank you very much for your work in this space. And also some comments around hope for the national standards and long-term care that are being developed will replace that aspect of control of long-term care. And then also enabling loving caregivers who will put the quality of life of their loved ones at the top of the agenda, and so they won't be excluded anymore. So lots of thank you in the chat to both of you for this really great presentation, for raising awareness and the attention that's being put on this important issue in our healthcare workforce. So thank you both very much. So I'll be moving on to the next slide, just to mention that we do have some upcoming events in our long-term care plus programming and our virtual, so we have a virtual learning series on November 29th, which will be looking at the practices of interest to support in-person family presence and communication with families. Will be presented by Pamela Fancy and Janice Keefe. And our next long-term care plus huddle will be on November 25th, where we'll look at Vision Loss Rehabilitation Canada with Josie McGee. And we also have another learning series on December 6th, where we'll look at the promising practices for supporting long-term care providers' resilience. And so thank you very much to our speakers for your engaging discussion today. And we hope that all of you in the audience found this session informative. And thank you very much for joining us. And please complete our poll at the end of this webinar. So thank you, everyone, and have a great day.